Welcome back to our series on menopause. In this episode, we're stepping into the history behind one of the most influential and controversial moments in women's health, the landmark hormone replacement therapy study that sparked widespread fear and changed medical practice almost overnight. Today, we revisit what the study actually showed, who it truly applied to, how the findings were communicated, and why leading menopause specialists are now reevaluating its conclusions. And today we are going to talk about the evolution of hormone therapy and how we got to where we are here today. Joining me right now is Dani Balinski. She is from the CU Anschutz College of Nursing. She is a certified nurse midwife and Menopause Society certified practitioner. Dani, thank you so much for joining us today.
Of course.
All right, we're going to talk about the famous Women's Health Initiative study from the early 2000s. It sparked fear around HRT and really changed the approach. It impacted the approach of how women look at HRT. Let's talk a little bit about that study.
Definitely. I think this is really important to understand the historical context of how we kind of got to the current moment that we're in around menopause and hormone therapy for menopause. Prior to, the year 2000, about 40% of women who were in their menopausal transition and eligible to take hormones were using them. Compare that to where we're at now, where we think it's probably around 5% of people who could be using hormone therapy are using it. So there are likely a large number of people who are suffering needlessly, who could be safely treated if they chose to be. And I think to really understand why that happened, we've got to look deeply at the Women's Health Initiative, or the WHI.
Okay, so let's talk about the impact of that study. Why did that study have such a massive impact on HRT and how it was viewed by healthcare providers, how it was viewed by the public? Women especially became afraid of it.
Certainly. And so I want to kind of take a step back and kind of look at, why were we doing this study in the first place? And I think a lot of people when they imagine this study, they think it was to see if hormones were effective for treating menopausal symptoms. And that wasn't what it was looking at all. We actually have known for a long time that estrogen in particular treats hot flashes, night sweats, makes people feel better. We know that. The reason that this study was done actually goes all the way back to the 1980s. There were two studies. One is called the Nurses' Health Study, and the other one is called Framingham's Heart Study, that came out in the same issue of the New England Journal of Medicine. And the Nurses' Health Study looked at healthy postmenopausal nurses on estrogen and said that they had a reduced risk of major coronary heart disease compared to women not on estrogen. And then the Framingham study was a prospective cohort study, and that showed a 50% increased risk for cardiovascular morbidity among women over 50 years old on estrogen. So we had these kind of conflicting results that were published in the same journal, and people were like, what's going on here? And so it is really hard to kind of control in an experiment all of the things that go into our heart health, especially, right? Your diet, your exercise, your stress, all of these things can play a role. But we were really interested in knowing if, supplemental estrogen kind of past age 50 was playing a part. And so the Women's Health Initiative is a NIH funded study, and this particular arm of the study was looking at women aged 50 to 79, and it was specifically to evaluate their cardiovascular outcomes. And this is probably it is the biggest study that we have on kind of like safety data for being on hormones after your menopausal transition. The two arms of this study, one of them was taking a synthetic estrogen or a placebo, and those were only women who had had a hysterectomy because they could take estrogen alone. Then there was another arm that was taking the synthetic estrogen plus a medroxyprogesterone acetate, which is called MPA, which is a synthetic progestin versus a placebo. And so in 2002, the study was actually stopped early, and the report that came when they stopped the study was that we had to stop because there was an increased risk of cardiovascular disease as well as breast cancer, stroke, and pulmonary embolism in the treatment groups.
And so with that study, I think there were some misconceptions because what they're bringing forward now is that some of the women in the study might not have been as healthy, might have been older. So there were some flaws in that study, is what we're finding out.
So that's exactly right, Vita. When they stopped the study in 2000, it really did scare people. Those were concerning findings, and a lot of physicians and women just stopped using hormones kind of overnight. The findings were also heavily reported on in the press, and the way that it was reported was fairly alarmist and scared a lot of people. And then come to find out, they did a reanalysis of the findings in 2007, which actually showed that for women ages 50 to 59, there were further cardiovascular adverse events, and the stroke risk really increased after the age of 60, and the cardiovascular risk for women after the age of 70, which this is kind of where the idea of the window of opportunity comes from, is from this study. The reanalysis did show, again, a small increased risk of breast cancer for people taking the synthetic estrogen along with that synthetic progestin, but it actually showed a lower risk of breast cancer for the estrogen alone group. And whether or not people, passed from their breast cancer is kind of another question as well. And so that reanalysis kind of, made us pause and be like, okay, is this a safe option for people who, don't have other existing cardiovascular risk factors, don't have a history of a blood clot, things of that nature? But kind of while we were trying to sort this out, from 2002 to, I would argue, maybe about 5 years ago, no one was getting training in how to prescribe hormones for menopause treatment. And kind of in that space, some of the more dangerous, or I would argue kind of more deceptive practices that some, pellet clinics or compounding clinics kind of had space because no one else, you couldn't get this from your family doctor, you couldn't get this from your midwife or your OBGYN. And so people kind of turned to these avenues where they could get hormones that also might not have been the safest option. So it's really had a lot of implications that are going to continue to affect this space for a long time.
So, what are some things that we can learn from this study and the new analysis?
Definitely. I think that, while the study was not perfect, it's still the largest study on kind of like a hormone use that we have. And from this study, we got the idea of the timing hypothesis, which does tell us that starting within 10 years of the menopausal transition is safe and might provide cardiovascular benefit, although again, as we've discussed, that data is not strong enough to use for primary prevention alone. We also, from this data, there were other studies done looking at kind of different outcomes in terms of like, do we have cognitive benefit if we start early versus late, kind of like how big is the difference that we see? And then the breast cancer data, I think we would be remiss to ignore completely, because that is something that people will come in, knowing their family history and potentially talking about risks and benefits. The absolute risk was about one extra case in 1,000 women using hormones on the estrogen plus progestin arm. And so it is good data to be able to put that in context. Because one woman might hear those numbers, one additional case in 1,000 and say, absolutely not, that's not worth it to me. And a lot of other people hear that data and say, I understand the risks and the benefits, and I'm suffering with my symptoms, and this is an effective treatment that works well for me, and I'm able to contextualize the risks and benefits and feel good taking this. And that is really important. However, just because of kind of the media sensation, I think a lot of the benefits got lost in the noise of the risks. And that's where a skilled provider is going to be able to sit down with you, again, look at your specific risk and benefit profile and decide if this is something that will be safe. And then do you as an individual kind of understand your health history and the risks and benefits for you in particular?
Okay, so let's talk about this study. Why did this study have such a massive impact on HRT viewed by the public and even healthcare providers? And as you mentioned, it changed everything. It went from a higher percentage down to like 5% of women.
Certainly. And part of that was the way that these findings were reported. If you're being told that taking hormones increases cancer risk by 50%, that sounds really scary. But if we say it brings your risk of breast cancer from 1 in 1,000 to 2 in 1,000, that's still a 50% increase, but it kind of contextualizes it a little bit better. And that's the difference between a relative risk and an absolute risk statistics. But anyway, that is what a provider who has looked at this data is going to be able to walk through this with you so that you really understand what we kind of have, like what is our modern understanding, what can we take from the WHI that might be helpful, and what do we now understand was probably effects of, the way that they did enrollment. The women in the WHI trial were older, for example. And the reason that they were older is because this was a study looking at cardiovascular outcomes. And so if you're trying to wait for someone to have a cardiovascular event, enrolling older people in the study makes sense. There's also some thought that potentially people closer to like the age of menopause didn't want to be in the study because they didn't want to take the risk that they would get the placebo arm, right? If you're really suffering with debilitating hot flashes and night sweats, being in a study where you might not get the active drug probably doesn't sound great to you. So there were definitely some like practical limitations in the people who enrolled. And that's where that reanalysis that they did in 2007 is really helpful to say, okay, at an appropriate age, it does look like the cardiovascular risks are minimal. The stroke and the cardiovascular risks really go up past age 60 and even 70. And then in terms of the risk of breast cancer, again, preparations that were used in the WHI trial are not even necessarily the preparations that we'll generally be using today. However, if you have a strong breast cancer history, I think we still have to talk about it, right? We have to, can keep you up to date on your mammograms. If you happen to have or develop a breast cancer that is sensitive to estrogen, being on hormones certainly could make it worse. And so making sure that we're fully understanding, what we're doing and why and what would be reasons to stop is an important part of informed consent, which is, responsible.
Well, and you also mentioned the form of estrogen has changed. Back then, it was different than now, which we have an FDA approved bioidentical patch, which is completely different than what was presented in the study.
Certainly. And so generally, I think what we can say is that if you are, within 10 years of your menopausal onset, you are overall healthy, you don't have other, contraindications that would make hormones inappropriate for you, that the risk-benefit ratio, especially if you are, having debilitating night sweats, all of these sorts of things, is generally favorable. But it is a bigger conversation. I think we see a lot of kind of absolutes in our social media landscape, right? People are saying like, this is the best thing ever, this is the worst thing ever. And the truth is that it has to be individualized, and we need to really talk about the risks and the benefits for you as an individual and kind of your preferences and your values to make sure that we're making this decision together. And that is my goal as providing this care to people. I want to make sure that at the end of your visit, you understand what your options are, what is going to be appropriate for you according to your specific history. And then do you understand kind of, the risks and the benefits and what might be the tipping points to change those things? And again, that's going to be really different for every person.
So does a cardiovascular go down between 50 and 60, but then went up after 60? Or
that is what the WHI said. And because people weren't using hormones for the last 20 years, pretty much, we don't have a lot of data since then, even like retrospectively. So we think that the bioidentical hormones are likely safer, but there is a good chance that like if I started you on hormones at 70 and you hadn't been on them for the last 20 years, that's probably still bad for you. Since the WHI, we've also had, a couple follow-up studies trying to evaluate benefits and harms of menopause hormone therapy for, prevention of various chronic diseases. The big ones that people tend to be interested are, coronary heart disease. And the data remains mixed. And so hopefully we will have a better study, forthcoming that can kind of more concretely answer these questions, but our kind of like best understanding at this point is that if you are within that window of opportunity, generally hormones for your menopause treatment is not going to drastically increase, and in some cases might even decrease your risk of a cardiovascular event. But again, the data is not strong enough to say that we should be using hormones for prevention. And then as you get older, the chance that you have, various comorbidities that could, independent of menopause be affecting cardiovascular disease and heart disease risk is there. And so that's why we do yearly follow-up to be like, okay, now you're 60. How are we feeling? Do we think we can come down on the dose? If you've been on an oral preparation, would it be more appropriate to transition to a transdermal preparation? Different things to mitigate stroke risk and clot risk that also increase with age. And so that, again, is a really in-depth conversation. It has to do with your health status as a whole. But I think the main takeaway that we can take is that, if you are without contraindications and you're starting hormones at the appropriate time for menopause, generally the risk benefit is favorable.
As far as it's coming out now, there were some potentially flaws to the original WHI study as far as how it was reported to, patients out there through media, et cetera. The fear was that it would cause an increased level of cardiovascular events. However, what we're finding out now is that some of the women in the study were over 60, might have been smokers. But you were saying that actually the findings after further analysis, they went in and found there was a decrease in cardiovascular events for women, kind of what's called a window from 50 to 59, essentially.
Mm-hmm. Yeah, definitely. And so that reanalysis in 2007 did show fewer cardiovascular adverse events in women 50 to 59, which kind of further supports the safety of hormone treatment in that kind of window of opportunity that we talk about. And these are important conversations to have with your healthcare provider. They can help you understand the risk and benefit profile for you as an individual.
And also, too, I think the type of estrogen has changed. That was a synthetic estrogen and a synthetic progesterone. And now we're dealing with bioidentical options.
Mm-hmm.
Those are different treatments, very different than what they were back then.
Yes, certainly. And so what we are generally using for people is a bioidentical estrogen as well as a bioidentical progesterone, not 100% of the time, but often. And so we do think that the safety profile for that is probably even a little bit better, but we don't have the data at this time to say that 100%. I think another important consideration when we're doing, risk versus benefit is, are we looking at the benefit? If you are someone who is having like debilitating hot flashes, night sweats, not able to sleep, not able to go to work, having relationship disturbance at home because you're in such a bad mood because you're feeling bad all the time, all of those things matter. If you're someone whose mom had a hip fracture at a young age, your bone density. So it really is like looking at the big picture of your health, because those benefits we might weigh against some of these risks and decide that this is a, appropriate and acceptable thing to do. And again, we just got to have those conversations. And I really like to, show people kind of where we think we're at, and as much as we think is safe, let people decide for themselves.
So what were some of the key consequences of this impacting both the patients and the medical community?
Mm-hmm. Yeah, and so like I said, one of the, I think, worst things that came of the WHI was really the lack of training that medical providers received for the last 20 years. There's a lot of data that, in med school, residency, even for people who are going to be treating, women in their career, people are not getting training on menopause. People don't understand, the different hormonal states. People don't understand, if they are going to prescribe, how to really communicate the risks and benefits in a way that makes sense to people. And there are a lot of people who will go to, their primary care provider or whatnot, and they'll just be told that they're not a candidate for a reason that, doesn't really make sense because their grandma had breast cancer. That by itself doesn't mean you can't take hormones. Should we have a longer conversation? For sure. But I think there's still misinformation even in the medical community about what makes someone an appropriate candidate and what doesn't. Luckily, there are a lot more people being trained through various avenues. One of the big ones is the Menopause Society, which is kind of continuing to update the guidelines that we use for safe prescribing. So there are more and more people that can help, and you can find a provider on the Menopause Society's website and, search for your area and all that good stuff. And so hopefully more and more people who are wanting or needing hormone treatment or, even non-hormonal treatment for their menopausal symptoms will be able to access someone who has done some additional training.
Are we seeing any long-term health impacts from people avoiding or being denied kind of HRT due to that study?
I do think that one of the harder things for me working in this space has been people who have kind of like missed the boat, so to say. I have occasionally had someone, come into my office at 70 and they're kind of like, I suffered for years and years and years. And often they're kind of like past their symptoms at that time, but they are someone who absolutely would have been an appropriate candidate, would have been really helped for, their transition, and they weren't able to take it, which is, really unfortunate that was, a generation of women kind of going through menopause, and what we hope for people who are, approaching perimenopause or going through their menopausal transition now is that they're going to be able to access a provider who is able to help them manage their symptoms and live their life to the quality that we would want.
Okay, so what does the current research tell us about the safety and the benefits of HRT today?
Mhm. I think that's a great question, and I'm going to cite directly the hormone therapy position statement from the Menopause Society. And what they have to say is that for women aged younger than 60 who are within 10 years of menopause onset and have no contraindications, the benefit risk ratio is favorable for treatment of bothersome vasomotor symptoms and prevention of bone loss. For women who initiate hormone therapy more than 10 years from menopause onset or older than 60, the risk benefit ratio may be less favorable because of the greater absolute risk of coronary heart disease, stroke, venous thromboembolism, and dementia. So that is a long way to say that if we're kind of in that window of opportunity, we think that this is overall safe and can definitely improve people's quality of life. And as you get older and have, more effects just from aging and other chronic illness and this and that, the conversation does become more nuanced. And so the best thing to do is to talk to your provider to know what's right for you.
And in that window of opportunity, I know we've talked about it, but that's really that 50 to 59, correct?
Yeah, it's really going to depend a little bit because there are some people who don't have their menopausal transition until 55. So there's nothing like magic about age 60 necessarily. And this also brings up a good point in like, when are we stopping hormone treatment, right? We used to say like, shortest duration is going to be safest, and now we're not necessarily sure if that's true. If you're someone who started hormones kind of within their menopausal transition and you continue on it and you're well controlled and you don't develop a contraindication, then it likely is safe to continue, but we have to continue to evaluate your overall health status to make that determination.
The understanding of the timing and the types of HRT evolved since that study.
Mm-hmm. That's a really good question. And unfortunately, it is really hard to study hormone treatment in the context of all of these chronic diseases because a lot of them are impacted by things other than just being on hormones, right? Your cardiovascular health is impacted by your genetics and your lifestyle. And so these things can be really hard to tease apart. And it can be really hard to do kind of like gold standard randomized control trial because people often know if they're on the active treatment or the placebo. And I think that's one reason why the WHI trial remains relevant. Well, it definitely wasn't a perfect study. It is some of the highest quality data that we have to kind of speak to the relative risks and benefits of hormone treatment. That said, we do think kind of the more modern preparations that we're using are hopefully, safer.
So if you could re-educate the public on HRT, one thing, what would it be?
I think definitely I would come back to that, like in the absence of contraindications, hormone therapy for menopause is generally safe and effective, and working with a provider that can help you kind of sort through the noise and also consider if there's any particular outcomes that are worrisome to you, to really put those into a context that you can understand. That is going to be the highest quality and the best healthcare that you can receive around hormone therapy, whether you decide to go on it or not.
Dani Balinski, thank you so much for joining us. Great insight on a very in-depth topic.
Thank you for listening and being part of our Women's Healthy Aging series. If today's conversation helped you, be sure to follow and share the podcast. And stay tuned for more expert insights, practical guidance, and empowering conversations to support your health journey at every age.